some diseases we've been extremely successful. So some diseases have been completely eradicated. But viruses are still very prevalent, and we don't have vaccines for all the viruses that exist. And even if you have vaccines, we also have, which is growing issue, a proportion of people who just don't want to vaccinate because they don't believe in the power of vaccinations, or they have other motives. And that's actually a great problem in our societies these days. This table here is just to remind you of the prevalence of 3 major diseases, which I'm going to be talking about later on: influenza, gastroenteritis, and chickenpox. So I just picked those because those are the ones I have data on. And that afflicts quite a large portion of the population, 5 to 20% for the flu every year, 20 to 40% for gastroenteritis. Chickenpox is quite small because it's a very particular disease, which is extremely contagious, but you get lifelong immunity as opposed to the other 2. Okay, so 0.1 to 0.5% is essentially, that's the new cohort of babies or young children who haven't been exposed to that disease. Okay, the mortality rates, that varies a lot, and so this is relevant with the current crisis. It's extremely badly measured. Okay, so when you die, there's not a tag on your on you that says the death of influenza or gastroenteritis. So usually you die from pneumonia or some complications like that if you have influenza, and so it's difficult to record. Okay? So there are estimates which are based on rates of pneumonia and respiratory problems, for instance, and excess mortality. And so the estimates range between, in Europe, between 40 to 200,000, depending on the years, and the US between 3 and 50,000 or so. Gastroenteritis, at least for our countries, Western countries and developed countries, is not a killer at all. It kills people, but in third world countries. And so mortality is minuscule, something which will be important later on as well. Chickenpox, also not dangerous at all. Okay, not pleasant, but not dangerous, especially for a young public. Okay, for adults with chickenpox, this is actually a serious disease, but for children, it is not so much. Now, these diseases, not only kill or emotionally or so, but they also impose a large burden on the healthcare. Okay, so this is about between 1 and 2 million bed days in hospital. Okay, for influenza and gastroenteritis, chickenpox much less. Now, there is, as I said, there's limited scope, and we see this today with the COVID crisis for public policy. Okay, so apart from vaccination campaigns, the only method we know of since a long time ago, probably even before medieval times, is actually preventing people to meet and to spread the disease. Okay, but if you look at the literature, well, I think it's fair to say that we know surprisingly little about the determinants of how viruses spread. So we do have powerful mathematical models in epidemiology, but they're not so good on determinants. Okay, so essentially, for those models, you just bump it to someone else and then you transmit it. But there are more broader questions on the determinants, which is, how should we organize our societies? Should we travel? How should we essentially design, for instance, our transportation system and so on? And there's not much about it. Okay. So there's also a lack of knowledge, or at least so far, to know whether public health policies to limit contacts are worth it. And that's at the key point in this current crisis. because there's very little cost-benefit analysis. Of course, it's very hard to do, but this is not something that economists have spent much time doing, and this is certainly not something that epidemiologists have been thinking of. And so, in the sense, this paper, for what it's worth, is essentially starting to address this topic. And as I said, there's transportation is important in the spread of diseases, and there are unintended costs of expanding transportation infrastructure in terms of health. And this is something I will be looking at the very end of the paper. Okay, to get you an idea of the data I have in this paper, I just plotted here 8 weeks of data for 1993. So these are the weeks leading to Christmas of 93. And this is the flu-like illness or influenza in children. So this is France. So you can see the 20-something regions in France for which I have data. And the first week, everything is fine. Okay, everyone is anticipating Christmas. And in week 44, the second week on this graph here, there's something happening in Brittany, in Bretagne, which is in the west here of France. And there's a small surge in influenza in children, okay, which by week 3 is becoming more red, so more prevalent. And this is spreading in about 3 or 4 weeks. And becomes dark red in week 47. But in between, in week 45 here, there's also another region that is affected by the flu. Okay, whether these two regions are connected is it's impossible to tell from this graph. They seem to be pretty far away. One is in the west, one in the south of France. But it's not, maybe it's possible that something came from Brittany to the region of Montpellier, which is here. Or maybe it's just by chance, and that came from abroad or somewhere else. Okay. In week 46, you could see that it's spreading. It looks like the region in the south there, where Montpellier is also contaminating the region where Toulouse, which is nearby here, and probably the region in Brittany here also have spread the disease to the west of France and so on. Okay. So all in all, by Christmas, it looks like it's a miserable Christmas that year. Okay? For the whole of France is in deep epidemic. So this is essentially the data I have, and I'll be exploiting in many different ways. Okay, so the research questions here is, what are the determinants of the geographical and temporal spread of viruses? And so there are many questions that you may want to address, both as an epidemiologist and economics, which is, well, does that depend, or in the short and the long run, on economic activity, for instance? The second one, which is at the heart of the crisis right now, given the urgency, is are there any public health measures that can slow down or prevent the spread? And the question is whether they're worth it. And so in the short run, what I'll be looking at is shutting down schools, public transportation, and looking at mass gatherings. Okay. In the long run, then the question is, well, how society is organized and whether viruses are spreading more in the countries, and whether population structure and the density of population plays a role, infrastructure, transportation, economic cycle, for instance. So the contribution of this paper is that I'm going to combine data from many sources, well, primarily the one I pictured before, which are infection rates, which are on a weekly basis in different regions and for 3 different age groups. And this is high frequency data, but the good thing is that in France, this has been collected for a very long time. So I have a quarter of a century of data on a weekly basis, okay? And that's a long period, so you can see many epidemics happening, and you could see a lot of variation in the data, okay? So the variation we're going to look at is school closures, which are essentially due to holidays. And I'll talk more about that. Public transportation shutdowns. So France never shut down any public transportation because of an epidemic, nor has any country so far up to this crisis, really. And so there's no real data on that. But the good thing with France, though, is that the transportation is public, and they also go on strike quite a lot. Okay? So there's, over these 25 years, there's also a lot of instances of train strikes, either nationally or at least at regional level. And those occur sometimes during an epidemic or just before or just after. And so you can look at the effect of public transportation shutdowns in a rather exogenous way. Okay? During that long period as well, this was a time where France was rolling out its high-speed railway system. And the question is whether viruses are then prone to travel more once you open a high-speed link. Okay? And finally, I also have data on economic activity, trade, population structure, etc., across time and region. So I'll be doing things in different ways. First, in a very simple way, which just event study analysis to look at short-term measures that do not require a lot of assumption. Okay, so it's just a bunch of graphs, essentially. And then I look at something a bit more, well, structural is, well, why not? Actually, that's a good term. So it's based on a model. An epidemiological model, and this will be used to estimate the short run and the long run determinants of viral spread. Okay. I'm not sure if I'm missing questions or you're just very silent. I assume that it's fine. So we assess then the efficacy of public intervention, and we show that some intervention can be profitable, but not on all types of diseases and not on all types of epidemics. So literature, maybe I skip that. So I mean, just to say there's a very large epidemiology literature on viral spread. Essentially, that's actually quite interesting. Quite interesting literature. It dates back to 1927. That's probably the earliest paper I've ever cited in my career. And so this is something that epidemiologists have thought about for quite some time. Okay? So these are very nice models, dynamic models, probably even before economics spent time thinking about dynamic models. But for a long time, not much happened because those models were a bit hard to solve and especially to estimate. Okay? Then in the 1990s and the 2000s on, then with the help of computers, things were, and then they essentially used a lot of simulations. Very little estimation per se. So it's a lot of calibration. So that would appeal to the more macro part of the audience. But it's not so much the case that there would take a model and essentially estimate on data. Okay, so it's more calibrated, saying, well, there was a school in Singapore and where the kids met on average 5 people, and then they spread it there. So the rate of transmission is calibrated at X. Okay, and then with these numbers, then they would simulate a large number of scenarios. So that's what you see essentially in the literature or in the public debate right now. So the Imperial College study was essentially based on those type of models and those type of calibrations. In economics, we've been thinking about viruses as well. There's a kind of early literature in the mid-90s by Pierre Geoffard and Thomas Philipson on rational epidemics, and then there's some more contributions there. Essentially, I think because economics is very much studying behavior, there's not much behavior you can actually model when you do gastroenteritis. So most of this literature in economics is focused on HIV mainly, where you can model health prevention, behavior, and so on. So that's the large part of the literature. Then you have the paper by Delgado, of course, on the Spanish flu, and some other papers which are a bit less related. Okay, so I'll start by showing just some data and some simple questions. So for instance, have incident rates increased over time? So do we get more flu or not? These days, do epidemics spread faster with time? So these are, you don't even need an event analysis, but just look at the data, and then I'll do the rest. So as I said, the data have weekly infection rates between 1984 and 2009. I have 3 groups, children, adults, and elderly, and 21 regions in France. And I'm focusing on 3 major viral diseases: influenza, gastroenteritis, and varicella or chickenpox. Okay, how the data was collected? Well, that's coming from a network, an official network that the French government set up of, at the time, about 1,200 French GPs, and they were reporting back every week the number of cases they've seen in their surgeries or at home, if they're visiting patients at home, and that would be sent back to Paris and then collected and recorded. Okay, so that's the main data. Why 3 diseases? So there are slightly more diseases recorded, but with less time span. But it's interesting to have 3 diseases here because these, well, or viral disease, but they also are very different in the incubation period and the way they spread. Okay, so that gives a bit perspective on how successful policy can be depending on the nature of the virus. So this is a typical graph here over time. So you see the first one, flu-like illnesses. You have here peaks every year, essentially. So that's the epidemic. Sometimes it's more severe and you have more people getting it, and some years are very mild. Okay, same thing for acute diarrhea. You have, it's recurring every year, essentially, and with different degrees of severity. Chickenpox is a bit more messy, but essentially it happens every year with some spikes as well. So it's very kind of not seasonal, but at an annual frequency. Okay, vaccination rate. This is for the flu, just because that's going to be important in the modeling. So vaccination rates have gone up in France, especially among the elderly. There was a push in the mid-80s to mid-90s. And then it kind of stagnated. Okay, in children and adults, it's still, or at least up to 2010, actually very minimal. So the first thing you can look for is a test for trends. Okay, so essentially, just looking to see if there is just more people who are getting the flu or diarrhea over time, and so the different numbers here. So if you look at the flu, it's essentially, you can see it tends to go down, okay, especially in the elderly, which is probably due to the fact that there are more vaccination. Okay, acute diarrhea, on contrary, is essentially been increasing over time by about 2.4 to 2.5%. Especially well, outside of the elderly group. Okay, and chickenpox is very stable, essentially because more or less everyone in a cohort, in the birth cohort, will get it. Okay, so maybe it's negative here for flu-like illness because of vaccination and the success of vaccination. Acute diarrhea is probably on the increase, perhaps because we're just traveling more. And there's no vaccine for diarrhea, so what you pick up here is the sheer effect of how society is organized and how this virus is traveling. Okay, that's another way to look at the data. Now we'll just averaging over the years, but looking at the pattern over the year, so different month from January to December. And so what you see here is a pattern which is almost the same between flu and acute diarrhea. There's in the beginning, January, February, March are visible months, as well November, December. So that's where the epidemic is spreading. But by May, essentially between May and September, there's very little cases in terms of flu. Okay, that's because the virus is very sensitive to temperature, and during the summer, the virus just goes south to the southern hemisphere where winter is occurring, and then comes back in the winter to the northern hemisphere. Okay, it's much more prevalent in children because they have lower kind of immunity system. They haven't seen the virus before, so they get sick all the time. And it dips in December here, just anticipating a bit from the next time. It's not so much that they're all on vacation and no one is recording the cases during December. It's essentially the effect of the school break here for Christmas. And the school break has this huge effect on the prevalence of this disease. So it breaks it down and then it reappears when children go back to school. Okay, same thing for the adults, you can see here as well, but to a much smaller degree. Okay. Acute diarrhea is the same pattern. It disappears during the summer, except for children who, that's less prevalence, but it's still there. Chickenpox is a disease that takes a long time to incubate. So it's less sensitive to short breaks or vacation. It kind of plummets here during the summer break, either because it's also sensitive to temperature, but also more so because it's school here is, or children are away from school for 2 months, and that's a long time period. And that kind of breaks the contamination or the propagation of that disease. As you can see, it's almost inexistent in adults and elderly, so I won't really talk about that. So the next question here is, do epidemics spread faster with time? So you would think that in a society where you travel more and more, the virus is just going to spread faster than they were in the 80s, for instance, okay? Because we have better transportation infrastructure, transportation is cheaper, more people are traveling in general, okay? Why do we care about that? Well, because I mean, as we see today, an epidemic that is spreading very fast, you know, it just clogs up the hospital. It's much more difficult to control, and setting up measures just take time. Okay, so you could do that by looking at the data. So essentially, what I'll be looking at is the time in each year until we reach a peak of the epidemic. So by September, if you take, for instance, the flu, there's essentially no case, or during the summer, there's no case. And then how many weeks does it take for the epidemic to essentially develop in a given year? Okay, so I'm just looking at the weeks until the peak. So that's easy to explain. It's a bit more difficult to do in data because there can be more than one peak in a given season. And it's a bit hard to define a peak formally. So what I did instead, but which looks very much like the peak, is essentially looking at the time to reach 80% of the total infection rate over the year. Okay, you can take out the definition; it doesn't change the results that much. So what I have is one observation per year, per region, and per age group, and per disease. Okay, so that's the number of weeks it took to reach this 80%. Okay, so if you look at the CDF graphs here in Alsace, the 80% is up here. And so I would count the number of weeks up to this point here. Okay, and the same for different regions. If you do that, then you do find a negative trend. So that means that with time, as when time goes by, essentially the time to the peak is diminished. So these diseases essentially tend to peak much sooner than before. Okay? That's true for flu-like illness and also for acute diarrhea. So that's the first indication that something in our society has changed, and those viruses just circulate apparently much quicker than before. Okay, so let's look at short-run measures. So I'm going to look at school closures and public transportation shutdowns, and I'm going to do that within a region. So I'm going to look at the prevalence of the disease over several weeks, just before, during, and after either school closure or transportation strike. Okay, and I just skipped this slide. So essentially, it's just an event study. So I probably shouldn't spend too much time on that. On the left-hand side, you have the incidence rate of region R and week W in year T. You project that on regional dummies, on week dummies, and year dummies. And essentially, what I'm be plotting next is these coefficients here, where X here is the dummy for the first week of either the school holiday or the train strike. I also include temperature, given that these viruses are sensitive to that. And I'm going to allow for some autocorrelation in the year return. Nothing really new there. This, just to show you so the school holiday system in France. Okay, so I gathered all the school holidays. These are set 3 years in advance by the ministry, and it's set for all schools. So all schools follow a given pattern, but the pattern differs across region. Okay, so if you look here in 1999, the blue period are periods where the children are in school, and this red one is when they are on holiday. You have here weeks from 1 to 50, which is well, the end of the year, Christmas. And then you have region 1 to region 21 in this. It doesn't matter which region is which. You can see that during this time here, you have, around this part here in the middle, this is the summer break. Okay, the one at the bottom here is the Christmas break. So everyone goes on the Christmas break at the same time. But when you take those vacations here, which are the winter and the spring break, it's staggered. So not all regions are actually on vacation at the same time. Okay, so region 1 is on vacation first, the region 2 is last, and then region 3 here is in between, etc. And that's staggered across the year, but in 99, but in 2000, it's not the same pattern anymore. So region 1 is essentially goes there in the middle, and region 2 is the first one to go on vacation, and region 3 is the last one, etc. So that varies every year, so you get variation, even when you condition on a region fixed effects and week fixed effects. Okay, so you have a lot of differential variation. Also across years, the summer break does not take place in the same time. And the one at here, which is the All Saints break, or the fall one, essentially comes at very different times. Okay, so that gives us a lot of independent variation. So when you look at the effect of school closure, well, this is a classic event analysis. Essentially, on the first week, of the first week, you could see a sharp break or sharp reduction in the prevalence, about 20 to 25% drop in the prevalence. This for children, adults as well. There's a decrease in the prevalence. And the prevalence is essentially below normal for 1, 2, 3, 4 weeks, essentially. So usually the children are on vacation for about 2 weeks. Okay, so up to here, they would be out of school, and then they come back to school, and that's a time where you see that the prevalence is on the increase again, but it's still below what it was before the break. Okay, so these measures are effective. They kind of cut the contagion or the spread of the disease, not only well during the break, but then that has a lasting effect, of course, because some of the kids well, have been sick and then are not transmitting it anymore, and so this prevalence is smaller. And then it goes up again after a while. Okay, so school closures also affect the adults, as you can see, and but perhaps a bit less so effective, but still. And for about 4 weeks again, that's below trend. Okay, for the elderly, there's a small effect, or it's not very precise, but it looks like it's significant and reduced, at least in week 3, and mostly in week 4 and 5. If you look at diarrhea, so a different type of disease, this has a sharp decrease already in the first week here. It's less sustained. So this is a disease which is more contagious than the flu, but also with an incubation time, which is much shorter, typically 1 or 2 days. And so you don't need to close the school for that long for it to have an effect. It has a knock-on effect also on the adults, but it's much shorter lived than for the flu. And there's not much effects here for the elderly. Transportation strikes. So this is typically French. So there are many during that period. I think I have between 18 to 28 weeks of strikes per region out of all the weeks I have. So I have a question here. If you only have 2 weeks of difference in vacation timing, how do you evaluate longer term effects? From what we know about event studies, there may be a lot of extrapolation going on in longer run estimate. So indeed, essentially what I can evaluate with this data is essentially what happens to 2 week breaks, because essentially, if I go back to my graph here, the breaks, the school holidays that happens during epidemics, which means during the winter or the cold season, are essentially those here. So probably a bit of the, well, this one, which is the winter break and the spring break, and the Christmas break, and this one, which is the All Saints break. Okay. So you don't have any epidemics, at least flu and diarrhea during the summer, so I will never be able to do that. Okay. There is nonetheless, if you close school for 2 weeks, there's a sustained effect. Okay. So there's some dynamic effects there, but the data I have do not allow me to evaluate what happens if you were quarantined for 2 or 3 months, as we're probably going to be. Okay. More noisy for the elderly. Sure, there's a problem of small n, so there's fewer of them. And they're probably also affected by many other things. It's a bit unclear. But it's just something I noticed in the data. It's much less precise for the elderly than for the other groups. Probably also because they have some immunity, because they were young once, and they were adults once, and so they've been exposed to many of these diseases, and perhaps some of them are also more immune to some of these strains. It's not impossible. Another explanation, which is probably a bit more grim, is that they may not show up in the data here if they don't make it. Coming back to so this is the frequency of strikes. So you can see there's, oddly enough, there's never any strikes in the summer month, July and August. Most of them are in November, December. This is usually about pay for the next year, and also in the early part of the year. Okay, so that's good for the analysis, because that's essentially when these epidemics occurs. Okay? So they essentially are timed, not because of the epidemics probably, but for other reasons, but they just happen to be in periods where there are lots of viruses around. Okay? Now, this being France also, some of these strikes here are pretty long. So the average duration is about 12 days, the median is 8 days, but I also have strikes that last for quite some longer time here, up to 50 days or so. Okay? That was in the mid-90s. So if you do the same thing here, essentially, so this for flu-like illnesses, there is indeed also a drop in prevalence the week of the strike, and it's not very sustained for long. Well, after 1 week, essentially the strike is off. So this part is after the strike, and in week 2, so 2-3 weeks after that, essentially there's no much effect. Okay, but there is an effect on children, and there is an effect on adults here, at least for the flu. And for the elderly, not much is going on again. It looks below trend, but it's not very significant. Okay, acute diarrhea. This is a virus which essentially, for which this type of policy measures does not seem to be working at all. Okay, for whatever reason. So we may speculate why this is the case, but empirically what you find is essentially shutting down transports is not a very efficient way of controlling this disease. Okay, so it's mixed evidence. It depends on the type of viruses. Okay, and it also depends on the age group. So this is very short term, and so what you want to do, and this is within a region. And so, of course, the virus is also spreading across a broader geography, and so what you want to do is to try to tackle that as well. Okay, but that you can't do with an event study. So what you need is some more complicated model. So let me spend just a few minutes. I have time. Well, I don't have that much time, but so this is a standard epidemiological model that classifies people in 3 bins, S, I, and R. S is the people who are susceptible to the disease. So these are people who are at risk, who can catch the disease. I is the fraction of people who are infected. And R are those who are just recovering from the disease and are temporarily immune from that. Okay? And that's at any point in time, you can just put these people in these 3 bins, and that's equal to 1 here. Now, the infection is spreading through this 3 differential equation. So the number of new cases of infected people, that's determined here by this coefficient alpha. And this is a model where essentially people bump into each other. So whenever someone infected here bumps into someone who can be infected, who is susceptible, then there's a share of alpha of those meetings that leads to new infections. Okay, so that's how you augment the number of people who are sick. And then those who are sick here, they exit this state or this bin at the rate of beta, and they would enter the pool of recovered here, okay, of people who are recovered. And then after a while, you've been recovered, you may exit this bin at the rate of delta and become susceptible again. So typically, if you deal with the flu, then essentially after 1 year or so, this new strain of the flu that comes back, you're temporarily immune to that strain, but next year, essentially you would exit this bin here at the rate of delta and become susceptible again, okay? Beta here is how long you stay, which is related to how long you stay sick, okay, which is a few days to a week, or 2 weeks in the case of chickenpox. There's not much you can do, so that's just a biological constant. You know, it's like a kind of a chicken soup coefficient. I'll come to measurement later on. But what you can do is you can affect alpha. Okay, so if you prevent people from moving, then you would bring alpha, or to meeting, then you essentially bring alpha to 0. Okay, and alpha is determined essentially by what people do, and that's how society is organized in general. Can I say something about measurement? Well, I will do precisely that. So I'll defer that question to a few next slides, okay? I have nothing to say about COVID-19 and immunity for sure, and no one knows that for sure. Okay, so let's skip this. So in the long run, alpha may be determined by epidemic progress. For instance, you vaccinate people by infrastructure, population structure, growth, trade, whatnot. Okay, how you work, if you work in crowded space, if you work from home. And in the short run, this is more about the policy measures we just looked at, maybe fluctuations in economics, and probably weather as well. And I'm going to look at differential effects within and across regions. Okay? Let's go to model number 1. So this is just the within region, just to fix notation and so that I understand that well. So on the left-hand side, I have, again, the incidence rate in region R in period T. And so this is essentially just the discrete version of the simple epidemiological model. Okay, so you have here the number of people infected in the past in a week, tau weeks from period T. This number of susceptible people who can meet, and that generates new infections. Okay, or that increases the incidence rate. X is going to be a vector with fixed effects, essentially time and region, etc. And then we have an error term here. Okay, so this is just the very simple model. Now, sorry, now, so I have data on I, but I don't have data on S. So that's, I guess, the question from Kalina, I think, or someone before. So you have to construct S. So this is the fraction of people who are susceptible. So for instance, for the flu, those who are not susceptible to the disease are those who are essentially being vaccinated. So you have to take them out. And as the flu progresses, and this is the concept of herd immunity, you have more and more people who are recovered and immune. And so the number of susceptible individuals decreasing. So as you progress during the year, S is decreasing. And so the rate you get new infections is also going to decrease. Okay? So how do I construct that? Well, I do it differently for different viruses. So for the flu, I take into account vaccination, and then I just count the number of people week by week who have had the disease, and I assume that within that year you can't get it again. Okay, which is not totally true, but which is mostly true for influenza. It's not true at all for gastroenteritis, for instance, and there's no vaccination there. So the susceptible population is essentially the whole population, minus those who are currently sick, essentially. And for chickenpox, this is essentially the new cohorts being born, or just born 2 or 3 years before that. 15 minutes. Okay, so let's skip that. Okay, so if you do this estimation, what you get is in children, so each individual here is going to infect 0.28 patients within the region, children, 0.45 adults, and 0.12 elderly, essentially. Okay, so this is how the disease is spreading across the population. Acute diarrhea has, different or significant coefficients as well. And I can't see the chickenpox on my screen, but this is essentially just children, and it's coming up there. Okay, so that's just within. Okay, just to show you. Now let's move to another model which has now within and between region spread. Okay, so the first part is the same as before. We have people who are infected, people who are susceptible. But now within my region R, I can also be infected by people who originate from other parts of France, from other regions. Okay, and so the susceptible in region R may interact with people who lives or are coming from region C here, where region C is from any region but my own. And so that's cases here would essentially be brought to my region. So within the region R, you get those who are contaminated from people coming from within the region and from people coming from other regions. Okay. Now, I don't have that much time here to talk about this, but you can allow for measurement error because these are just measured quantities. We don't know for sure the exact number of patients. And that's essentially introducing complications in the estimation in the sense that when you do the math, you end up with an error term here, which depends on the original error term you had, but also on lags of the measurement error, on the measurement error itself here, but also lags of it. And the left-hand side, the right-hand side variable as t-1 and the infections here as well. So measurement error essentially is screwing up the estimation. So there's a reason to believe that OLS is not the best estimation method, okay? Which is a bit unfortunate because that's essentially by and large what is done in epidemiology. So you have a lagged endogenous variable, this S times I. Essentially, you want to instrument that. And what I use to instrument that is to use weather histories. Okay, so the number of days with different temperatures and precipitation. Okay, I skip that. There's an F-test, there's a first stage, which is significant. I just skip that for the sake of time. And now I can estimate a model either by OLS or IV here, which gives you how each individual is contaminating within the region and outside the region. So for instance, a given sick individuals with the flu will contaminate 0.2 children within that region, 0.3 adults within that region, 0.1 elderly within that region, and then a number of other people outside of that region, in the rest of France. But there are many people in the rest of France, so these coefficients seem small, but in fact they add up. So in total, an infected individual with the flu will contaminate way more than one individual. This is how this epidemic is spreading. Okay. Now I have a more ambitious one, which is a model which is the same as the model 2, but where I let the coefficient alpha, which before just a number, 0.2 here, that will depend on a number of region characteristics, which are potentially time varying. So within and outside the region. So this could be school closure again, transportation strikes, but also weather, population density, trade between regions and so on. Okay, and that gives a more complicated model, which I will skip because I have very little time. I skip this too. And what you get here is a model which has essentially holidays, the effect of school holidays on how the virus is spreading within and between regions. So we've seen those coefficients before, sorry, the first line, which was essentially the event study. What we didn't see was the school holiday spreading out across region, and this is what it gives you here for different diseases. Okay, same thing with transportation strikes, which gives essentially more or less the same numbers or magnitude than the event studies. What is new and perhaps more interesting here is, for instance, the high-speed train. So high-speed train, as you can see, has always a positive effect on the spread of diseases. Okay, so it's essentially the high-speed train program in France increased indeed the propagation of diseases, okay, in a significant way. Okay. I also have other measures like trade. So within region doesn't do much, but when there's more trade between two regions, that's also increasing the rate of propagation of disease. It's also linked to business cycle, unemployment. There's some effects here, but I want to move on to other things. Temperature matters, population density as well, and distance in general measure between region matters to some extent. There's also some evidence that the epidemic is spreading asymmetrically over space from more dense region towards less dense region and not otherwise, and from 5 minutes, well, from poorer regions to richer regions. Okay. So in the last 5 minutes, essentially, I'm going to skip this cost-benefit analysis. Okay, so here you can collect, and I did that, all the costs of treatment, and GP visits, complications, death, etc., productivity loss. Okay, and you also can collect data on the cost of the policy, and then you can simulate the policy for every possible week during the year and see what's going on. So from the estimates before, if you implement a school closure here, say in this week, here in early December, you would reduce the prevalence by this much here. Okay, so by 4%, or this diarrhea, say from flu, by about 12% here. Because the schools are closed during Christmas, there's no difference in closing them or imposing another closure, so the effect is 0 here. And then you see that there's bigger reduction if you close schools during the winter than during the summer or warmer periods. Okay? Same thing for transportation shutdown. They're much more efficient in reducing the prevalence during the epidemics, or the season of the epidemics. Now, there's a lot of cost here, which I painstakingly collected and added up. And so you have both death and the cost of death, but that's actually very small for children, given that they hardly die from influenza. The biggest cost essentially is loss of human capital. This is calculated over the whole life cycle, and the parents staying at home. Okay? Of course, when you go to the elderly, they don't work, so they don't lose productivity, but they have a much higher risk of dying from the flu. So that's the main cost of that of the disease. Okay, and school closure, I did some calculation on how much it costs. Same thing for public transportation. In the short answer is it doesn't cost that much, actually, surprisingly, from the strike episodes. Now, if you calculate the overall cost benefit for the policy, this is for in euros per capita. This is for, it's not written here, but it's the flu, I think. Essentially, it always comes as the cost. If you close down the schools in November, for instance, it comes at the cost because essentially it's just too costly. And the costs are bigger than the benefits. Okay? So there's no period on average which gives you a positive benefit of closing schools. Same thing for transportation closure. Okay. Now, if I were to tweak the parameters here, and I'm going Ebola style, say for influenza, so I just increase the mortality rate of influenza. So this is not completely unlike COVID-19 right now. So as you see, with for a regular flu epidemic, it's never good to close neither schools or public transportation. Now, if you increase the lethality of this virus, essentially you come at a point between 2 and 3 where it's essentially become efficient to close this well, schools and transportation. So question here believes that people having gone through COVID will be immune. Yeah, well, if he believes that, that's fine. Sure, okay. Well, yeah, what can I say? Okay, and just to finish here, what you could do also is to look at the cost of transportation infrastructure in general, which has been done. So the econ literature has looked at the benefit of linking two cities together. There's a number of papers doing that. One thing which has not been taken into account is this externality on the contagion. Okay, so what I do here with the estimates I have, I essentially close down, or I do a counterfactual where I close down one high-speed lead rank in France, so say between Paris and Strasbourg, and look at how that reduces the propagation of the disease. Essentially, when you add up all this, you get to a cost about 80 million a year most of it coming from a reduction in flu-like illnesses. Well, when you add a link, you add 80 million per year in costs, which is coming from increased flu-like illness. Okay, that's a bit lower, but at the same order of magnitude in the gain you get in terms of time saved by traveling by high-speed trains. Okay, so it's not trivial, and this is something we haven't spent that much time on. Is how we should organize our society, essentially to counter the spread of diseases. Okay, so this is a paper that certainly does not answer all the questions, but contributes to that. Okay, and I'm done. So time's up, says Maria. Anyone wants a question or times for question or?
Okay. Thank you. Thanks, Jérôme, for this. And thank you all for joining. At some point, I saw we had 67 people, so that's quite impressive on such a short notice.
Indeed.
Yes, Christian wanted to make an announcement, but also please send me any feedback, how you found this experience, if something didn't work or something worked well, so we can take it forward. And then, yeah, I'll leave it to Christian.
So as a presenter, I must say it's very difficult to not have an audience to look at. Yeah.
So perhaps everybody should put a picture on the Zoom thing, so the presenter can look at that.
At least, yeah.
I think if there, I mean, so we are not completely restricted in terms of time. If there are some questions, and because we are not so many, perhaps you could just switch on your microphone, ask the question, and then switch it off again, and Jérôme can answer the question. Anybody who would like to ask something or comment on something?
I'll go for a question, if you can hear me.
Yeah.
So do you view the negative coefficient you get on unemployment as a kind of vindication of the kind of deliberate decrease in employment measures that we've had from governments?
So I think this is more of a long run effect. So it's not the unemployment in that week, which I can't measure. So it's taking over the last year or so. So it's not an effect of the crisis per se. It's more, I think, a contribution to the literature that looks at business cycles and health. So there is this important but also striking paper that says that people are in better health during crisis, economic crisis. And one reason, so by CReAM, which he attributes to better health behavior. But one way this could essentially also work is to reduce the circulation of viruses, for instance, which is certainly in line with what I've shown here.
Okay, any other questions?
So based on your research, would you dare extrapolating to corona? So, you know, we know that the elderly are much more susceptible than kids and adults than, say, in the case of flu. We also know we're hitting the hotter months, and different countries are implementing different policies with respect to schools and public transportation. So it's a gut feeling, but your gut feeling is more informed than ours.
So, I mean, the debate is whether this virus, I think the big question is whether this virus is sensitive to temperature. If that is, then, you know, whatever we do, it will have, I mean, it will tend to reduce, but we don't know that for sure. Previous, so this is not the first coronavirus we're exposed to. Essentially, it circulates in different versions every year, and several of them are circulating all the time in our societies. But this particular strand, we don't know for sure what's going to happen or how sensitive that is. But in general, other coronaviruses are sensitive to temperature.
Okay, any more comments, questions?
I have a couple.
Kirill.
Yeah, I have a couple questions. So, you mentioned that you measure how trade between regions affects the spread, but you don't have bilateral data on the spread. So I was trying to understand how you can identify that, or is it the overall trade of a region?
So it's the overall trade. So again, this is not a week by week trade. So it's the trade in the last year or so. So essentially, I know how much trade goes from A to B and B to A, but I also have instances where A has an epidemic starting a bit earlier than B. So I can see whether in that year, the virus tends to spread from A to B.
Oh, so you measure the kind of trade weighted average. Oh, that's really cool.
Yeah, it's like I guess gravity or something like that. I'm not a trade economist,
more of market access kind of. It was my other comment that you referenced papers on transportation like Donaldson, but not something which seems more relevant here, which is like Donaldson Hornbeck market access approaches, where again transportation acts as affecting the weights at which you're dependent on the epidemic in another region. And so it would be, instead of interacting, I don't know exactly how you look at high-speed trains, but it looks like there's an interaction with some disease, some prevalence of disease elsewhere. But it sounds like it's not an interaction; it's affecting the weights with which you aggregate.
Yeah. So it essentially affects the speed of transmission.
Yeah. Mm-hmm.
Yeah.
And last thing, is the data available?
So the data is available. Actually, that's how I started the paper. I just stumbled into by chance on the website in French. If you Google Sentinel, it's there. The only thing is that the version I have is actually a restricted one because it's by age groups. So the public access one has just for the whole population, but you have that by region, by week, etc. You have many more diseases than the one I used, if you're interested in that.
So for do you have the code available so that one can combine it with the publicly available data and take a look?
Sure. Yeah, it should be on the. I must have posted that on the QG website.
I looked, I didn't find, but.
Oh, okay. Yeah, well, I can send it to you.
Thank you very much.
Yeah.
Okay, so I have a
question I'd like to ask, if possible.
Okay, sure, please.
Hi, Jérôme. It's
Hi.
There was this paper that came out just this past week, a macro paper by Eichenbaum, Rebello, and Trabant.
Right.
Trying to take the SIR model and mix it with a macro model.
Yeah.
I was wondering if your paper can give them some basis for some calibration that they've done pretty arbitrarily, I would say. And more specifically, they presume there that an infected person has 80% of his or her productivity, retains 80% of it, or loses 20% of productivity when infected.
Okay.
Is there anything you can say about productivity in these macro terms?
So I had to say something when I did the cost-benefit analysis, and so I have a table on that. So I had 50% reduction for 0.7 days and 2 days away from work. Essentially, that's how I cost that for influenza. That was taken from the literature, the epidemiological literature.
So you said 50%?
50% for zero. Okay, so you're absent from work for 2 days. And then another day, and on top of that, you're actually not super productive for a bit less than a day, and you're working at 50%. It's not that far, I guess, from what you said, but that's what I gathered from that literature.
I see.
But yeah, you can play around with those numbers. But yeah, I mean, I haven't read the paper yet. I mean, people have sent it to me. Sure, it could be used to calibrate it. Yeah.
Yeah, it would be good if you could link up. Well, I'll send your paper to Marty anyway. I'm not sure he's aware of it.
He is by now.
Oh, okay.
Yeah.
Okay.
Yeah, but apparently he wasn't before.
Okay. Okay, Jérôme, I have a very brief question. So I was wondering, so the epidemiological model which is discussed these days is the one by Ferguson and co-authors from Imperial College. Maybe you can just point out to us in which way that model is different from the simple model you have presented, and what are the key parameters that have changed as they have changed very dramatically their predictions about the course of the disease here in the UK.
So essentially, so I haven't read in detail that paper, so I guess it's in the appendix, but those models are essentially based on the same type of model as IR and variants of that. So you can essentially, so these are models which are parameterized with very small number of parameters. So here in this case, you just have 3. Essentially, so beta is essentially the length, 1 over beta is the length of the disease. So in this case of COVID-19, it's about a week or so. Okay, so that's a parameter, you already have it. Alpha is essentially something you get from calibration, how many people meet, and then essentially you can simulate this model. It's just a couple of 3 differential equations. The model can be then complexified. You can have different, more states than S, I, and R. You can have different compartments of the population, you can have different regions, and then you can have a bit like I have actually with the spread within the region, outside, or you can have different groups of individuals, for instance, or different segments of the population, and so you just can slice it up. Okay, in the end, it gets a bit more complicated mathematically, hence you need computers to simulate that forward, but that's essentially how this literature is working.
Okay.
Yeah.
Okay, so I think we should come to an end. Jérôme, thank you very much for your very interesting and timely presentation. So we intend to continue with our Braunbeck seminar series. We will usually do it at the normal time, Tuesdays, 12:30. And we will, well, each time, announce it on the CReAM website. Very soon you will see a series of seminars we intend to host in more or less the same way in the future. So we are all very new to this. And if you have any comments or any suggestions how we could perhaps make this or improve on this in the future, please let us know and send an email to Maria. Follow us on Twitter and follow us on our website. And yeah, so we are looking forward to a slightly different Braunbeck seminar series in the future. Thank you very much, in particular to Jérôme, but also to Maria and Tuan, who have done an excellent job organizing all this and setting this up. And thanks everyone for joining, and hopefully see you next time in the same space. Thank you. Bye-bye.